I did get an email from that. Nothing's so official.
I check my mailbox once this last year, it seems, because I never get anything. Yeah. Well, I never went to it at all. Just my last person would go check it.
Oh, it's a million times worse. Like, I'm going to enjoy as long as there's no false solutions, they can't figure it out.
All right, let's go ahead and get started. Thank you all for coming. As you know, most of you know, this speaker series is part of a larger program sponsored by the National Science Foundation for recruiting PhD students into the smart environments area. And part of that grant, there is funding to have a speaker series, a distinguished speaker series, and so we use that money to recruit experts from around the world to come here and talk about their research and learn about ours. And so today we have Dr. Tania Giovannetti, who is an associate professor in the Department of Psychology at Temple University, and she also has a joint appointment in the Clinical Psychology and Brain and Cognitive Science programs. And her general research area is in, I guess, neurocognitive functions of everyday tasks, and I think we're going to talk more about that today.
Thank you. Thanks so much for the introduction and for the invitation to come here today. I've really enjoyed my visit so far. I'm looking forward to meeting more of the students later. So today I'm going to tell you about some of our work in trying to sort of map out the breakdown of everyday tasks in older adults with dementia. Here's a basic outline of how the talk will go. Give you some background information about our methods and sort of our thinking, our approach to this problem. And then I'll tell you about some early studies that led to a conceptualization of this breakdown called the resource theory. And I'll tell you about an intervention that we developed that was based on this idea. Then I'll tell you about another newer group of studies that started to show cracks in the resource theory. And this is the omission-commission model, which is the newest way we've conceptualized the breakdown in older adults in their everyday tasks. And I'll tell you about another intervention that we've done that's sort of informed by this newer theory. And I'll end with a few sort of take-home points. Okay. So as the psychology students here know, in clinical neuropsychology, what a neuropsychologist does, or even in research, investigating cognition and research problems, what our approach is not to simply talk about cognitive problems in gross terms, okay? So you would never ask a neuropsychologist to characterize memory and say, yeah, there are memory problems here, okay? That's just not going to happen. What we're taught to do, and what I really fell in love with about neuropsychology, is that we think about cognition and try to map the architecture of a cognitive process like memory. And we can outline the different components of memory, the different subtypes of memory, okay? And we can assess patients for the different subtypes of memory impairment. And this assessment, this detailed assessment or detailed analysis of memory impairments helps inform what the etiology of the memory problem might be and may make some suggestions for treatment. So I was really struck when I was thinking about everyday functioning about what sort of the gold standard or the common approach to thinking about functional deficits was by neuropsychologists. They would simply characterize these as either mildly impaired, moderately impaired, or severely impaired, or maybe just impaired or not impaired, based on some questionnaires or just briefly talking to the patients. Whereas, in the contrast in thinking about memory, there's a detailed analysis and testing that took place, and that's just not, didn't seem to be the status quo for thinking about functional impairments. So this became, well, that was a little cue for, I have these cues, talk about cues, I have these in my it's surprising, right? Because patients' families complain about functional deficits. Neuropsychologists are often sought out in order to make some sort of recommendation about how a person should be functioning in their everyday life. And most patients, even with mild cognitive difficulties, face some challenges in doing everyday activities. So this became the focus of my research program. And what I was really interested in doing is first characterizing problems that especially older adults have in everyday tasks in order to build a model in the same kind of approach that neuropsychologists take to studying other cognitive processes. And then use that model to inform interventions, and then have, the model crumble, and then, we start again until we really get it right. Okay. And so to start, in order to develop a model, what we really wanted to do is define the tasks that were most of interest to us. In order to really think about cognition and brain and how it might relate to everyday tasks, we needed to narrow our focus a little bit, and we decided to focus on tasks that met these criteria. They have steps that must be completed in a particular sequence. They're directed toward objects, or they use objects. The selection and the use of objects is required, and they are they serve some everyday life goal. Okay. Another term was naturalistic action that you might see in the literature, but we've been using the term everyday action or everyday tasks. We use that term, and it's different, and we specifically don't use the term activities of daily living or instrumental activities of daily living that you might see in the literature, because we conceptualize our tests as a little bit more narrow in that they meet those three features, or they possess those three features. ADLs are more broad and might not necessarily be directed toward action. So ambulation might be considered an ADL, and these are important for independent living, but don't necessarily meet the sub-classification of tasks that we're interested in. So the next few slides will tell you about our methods, and then I'll tell you about our results, but most of the results that I talk about will have used these methods. What we do is we ask patients or people diagnosed with various types of dementia or people with mild cognitive deficits to perform everyday tasks in the laboratory. We've selected tasks that are familiar to both men and women, and we present them in a standardized way across all participants. So the object placement is standardized, the specific objects that we use are standardized within the experiment. We videotape them, we code their errors and their different behaviors later, and we also collect the data from normative groups, so we can identify what an error is based on our normative sample, not just us sort of sitting around and thinking about what our best approach might be, the way we might do the tasks. We've relied really heavily on the naturalistic action test, which was developed by Myrna Schwartz in Philadelphia. And this task has 3 different subtasks that increase in complexity. The first task requires patients to complete toast and coffee. The second one requires that they wrap present, and in that task there are several distractor objects that are in the environment, on the tabletop, sorry. And the third one requires that they pack a school bag and a lunchbox, and this task has a sort of junk drawer down here at the bottom that has some distractor objects as well as some objects that they need for the task. Okay, we've also used some other tasks that have been reported in the literature, the daffs, but most of our work relies on the naturalistic action test. And we look at the task in pretty detail for various different types of problems or different features. The types of coding that I'll focus on today are coding of errors, where I'll tell you about that in more detail, but we look at various types of errors that the patients make on these tasks. We also look at whether or not they detect or correct their errors, the error monitoring. And we look at the influence of different sort of task arrangements or different types of task instructions on errors and error monitoring. This is a listing of the errors that we code. I'll show you some videos with examples of these. The most common error types are omission errors, where patients fail to perform pretty significant chunks of the task. Sequence errors, where they perform steps in the incorrect order. Perseveration errors, or where they perform task steps repeatedly, either in quick succession or after some sort of time lapse. Substitution errors involve the use of a distractor object in place of a target object. And I'll skip spatial, but action addition errors are the performance of an extra task step. Again, I'll give you some examples of these. We sometimes collapse these error types into 3 larger error types. Omission errors, where the step's not performed. Commission errors, where this includes sequence errors, substitution errors, and perseveration errors, where a task step is performed and completed, but it's performed inaccurately. Okay, and then action addition errors, where an extra task step is performed, like I said. And I'll tell you about those capitalized letters refer to the cognitive correlates that we found with these different error types that I'll tell you about in a little bit. This is an example of what the task looks like. This is an older adult asked to make toast with butter and jelly. You'll see the bread on the left here. She she shows a sequencing error where she puts butter on the bread and then puts it in the toaster. There's the butter dish to the right side with the toaster, and she's putting butter on the bread right there. So you can see she does a pretty good job of spreading the butter. It's not that the whole task is performed inaccurately. It really is a problem with the sequencing of the steps. This is just a photograph that shows the kinds of errors where we the kinds of behaviors that we might code as perseverations, repeatedly stirring the coffee, and we've actually collected times from controls to see how long what the modal modal number of seconds are for a control subject to stir. If it's beyond that. This is one of my favorite errors I was showing Maureen earlier, a substitution error where we look at where we ask the patient to prepare a lunchbox, and part of that is to prepare a sandwich. And instead of using bread to make a bologna sandwich, she used the cookies, chocolate chip cookies, as her breading substance, and she put it in. She put bologna in between. I'll show you. This is the lunchbox. This is the bologna. This is the cookie that she's already placed there. This is the bag of cookies, and the bread is over on her left side. Again, you see, like, everything's really pretty purposeful. It's not like she's confused. Looks pretty goal-directed. And then she puts her sandwich into the lunchbox. And this is an example of how we would code where we would code an action addition error. This is the same lunchbox and school bag task. And here, this person's doing a pretty good job. She's packed the lunchbox appropriately. She's on the school bag task, and she's just filled the pencil case with pencils and rulers. And this is the junk drawer here. What she'll do is she'll take time to start writing with a protractor and a pen in the binder, something that really doesn't have anything to do with the task. Whoops. I think she drew some kind of a triangle or something. She's drawing with a ruler. You know, we had discussions in our lab about whether to code this as an off-task error. We thought, well, had she written a note like, have a nice day at school, we would have coded it as okay. But since it was just sort of this geometric figure, it didn't seem to be related to the task at all. She really seemed to be pulled by the object, to use the objects. Sometimes this kind of behavior is referred to as utilization behavior in the neurology literature. So that's a flavor of the errors. And what we do is we have a standardized scoring sheet for all of our tests where we've enumerated all of the errors that we've seen, makes code inter-rater reliability very easy. And from that, we can calculate standardized error rates that control for the numbers of opportunities for errors across tasks, because those opportunities differ pretty substantially across the task. This is how we code error detection and correction. We've started to look at micro slips in action, where these are tiny little misreaches for objects that then the participant pulls away their hand because they've realized that reach was an error. We also code when they say something about the error, if they correct the error, all of these, any kind of indicator of error detection. And we calculate also the proportion of detected errors that are corrected. So I'm going to tell you about a series of studies that were designed to test early accounts for how and why everyday task performance breaks down in people with neurologic problems. Some of these early accounts were developed as early as the early 1900s by neurologists who were looking at cases of individuals and trying to explain why problems in these tasks occurred. And some of the different accounts that were floated around were that these problems were due to problems with object knowledge, problems with understanding how to sequence the tasks, but none of these accounts had ever been really empirically tested with large group studies. They were always sort of described following some case report without a whole lot of rigorous empirical testing. So this series of studies were designed to test those accounts and look for whether or not specific cognitive deficits predicted a different pattern of problems on everyday tasks. And the spoiler here is that they didn't find this. And in fact, what they found was they found different error patterns, pretty strikingly different error patterns, differed across tasks. So here you see on the coffee task, okay, and this was a slightly different coffee task than the one I showed you, but that's not so much. The coffee task would show a very different pattern of errors than a lunch task, okay, within the same participants. Okay, so that was striking, right? It doesn't suggest that if there's a specific problem, they should show the same error pattern across tasks. Another piece of evidence that was kind of puzzling from these early studies was that these pie charts show the proportion of these error types across different populations. And there really was not a unique error pattern across different populations. Instead, every time we ran a study, lo and behold, we kept finding the same distribution of errors across pretty different patient populations. And these are people with dementia, closed head injury, left hemisphere stroke, and right hemisphere stroke. And another finding from this study was that for the most part across populations, the best correlate or the best predictor of how someone did on these tasks was their overall level of general cognitive functioning. Here it's shown by the mini-mental score, which just measures overall level of dementia severity, was the strongest predictor of other measures of specific cognitive functions. It beat out all other measures, predicted total errors and omission errors, about 32% of the variance there. It did not predict commission errors, however. So, in conclusion from this series of studies, okay, these were a series of studies that were initiated by my mentor, Marna Schwartz, was that you can't really use these specific deficit accounts to explain the breakdown of performance on these everyday tasks. But errors seem to be strongly influenced by the task environment or the task context, right? The different error patterns across tasks. And there seemed to be some sort of general effect of cognitive impairment on errors in these tasks. And no real clear specific deficit that seemed to account for functioning, problems in functioning. And this general sort of problem seems to really account for omission errors. And these findings and some others led to this resource theory of everyday action, where you don't see a specific effect of a particular cognitive impairment on error patterns. Rather, any type of cognitive deficit is going to give you the same pattern of errors, and that pattern of errors is going to be predicted mainly by the environmental context. Okay. These early studies also gave us some results about error detection, namely, not so surprisingly, is that people with dementia detect significantly fewer errors than control subjects. But what we were surprised by was that people with dementia, once they detected an error, okay, they corrected about 80% of the errors that they detected. Controls corrected 100% of their errors. But we found that was really kind of exciting, right? So if you can increase detection, maybe you can increase correction and accomplishment of the task. The other interesting finding was that error detection was not correlated with overall error rates. So you could have someone who made a lot of errors but was detecting them, and you could also have someone who made a lot of errors but wasn't detecting them. Okay, so those seem to be sort of separate processes. And unlike error rates, error detection wasn't related to the mini-mental or general levels of general cognitive functioning. So from those findings, we concluded error detection, errors that are detected are often corrected, and errors rates and error detection may be dissociable or distinct processes or distinct problems that people face. So based on these early studies, we developed an intervention that was driven by these empirical data. And the first intervention, we called it the user-centered intervention. The first motivation for this intervention was that the finding that errors were linked to some sort of general cognitive process, and that the environment really had a strong influence over errors. So we sort of thought about early cognitive studies looking at something called stimulus-response compatibility, where if you could increase the compatibility between the environment and the response, you would reduce the cognitive resources needed to complete the task and make the environment more congruent with the action and maybe reduce error rates. Okay, and these two stovetops show, this is the much more compatible stovetop. You're much less likely to pick the wrong knob to heat the burner here. Whereas there, you're playing a little bit of a guessing game. Okay? Here's the stove that you don't want in your smart home. I thought I could give you something worth in my visit here. Okay. And then the second motivation for this intervention was that this idea of increasing error detection might help promote correction and ultimately get people through the task. Okay? And from here, we thought about these therapies that are described, goal management therapies that require that you train people to develop insight, but we sort of didn't think that would work with this population. What we moved to was the human factors research that just promotes, that instills in the environment some sort of prompts, right, or alerts, like, you sure you want to delete your entire hard drive right now? These are supposed to work. And so we developed a user-centered version of the naturalistic action test where the task objects were arranged from left to right on the tabletop. People were told to work from left to right. And objects that were used for the same subtasks were sort of clustered together on the table. So on this side are all the toast tasks, and we put the bread with the toaster, the butter with the knife, and so on. And here they go to the coffee task, and then at the end, they're told to work toward this bell that has a cue that says, check your work. And they ring the bell when they complete the task. And we ran this on 46 dementia patients. It was counterbalanced across individuals. So it was within subject design. They came back and we counterbalanced the order. And it worked. We got a significant effective condition on errors. The red bar is the number of the mean number of errors on the error score. You can see it was really effective on the third task. And we also were able to demonstrate it was clinically meaningful because we looked at cut scores and we found that dementia patients in the user-centered condition were much less likely than in the standard condition to fall above the cut score from normative data. So they were falling in the clinically impaired range. 67% of patients were falling in the clinically impaired range in the standard condition, and only 39 were falling in the clinically impaired range in the user-centered condition. Interestingly, we got no shift in the error patterns across the two conditions. It was pretty stuck, like it was pretty firm. We got what we got in the standard condition, the distribution of errors were the same. And we also did not get improvement in error detection. We weren't able to change that at all across the two conditions. It was not significant. And as you can see, in both conditions, though, once the errors were detected, they were corrected at a pretty high rate. So from this study, we concluded that environmental adaptations that increase compatibility between the environment and the response and promote error monitoring, although we did not think that manipulation was effective, we're not sure. They could meaningfully facilitate everyday action by decreasing errors in the task, but they don't shift the error pattern and they don't change error monitoring. We also don't know much about how effective this approach might be in the real world, and certainly we can talk about training caregivers, but we haven't moved this into a real life setting. So, shifting gears a little bit, I'll talk about a more newer series of studies using the same methodology or similar methodology that started to show problems with the resource theory. Okay, because this series of studies was really designed to test the resource theory more carefully. And what we were finding is that it wasn't really holding up. And so these series of studies led to a newer model, the omission-commission model. And the first study in this series recruited healthy individuals. And what we were trying to do is really test the resource theory in this way. We developed a very challenging coffee making task. You can see the photograph up top. The participants were required to make 2 cups of coffee, 1 for Joe, 1 for Martha. Martha wanted the green travel mug, Joe wanted the ceramic mug, Martha liked coffee from Mr. Coffee Maker, Joe liked the drip kind of coffee. They each like different types of coffee. They each like different sugars. Okay, so you get the idea. There was a lot to learn here. And we trained the participants on this task, and we brought them, we looked at their performance across 2 different days. And what we thought was that on early trials, which we called early practice, okay, they did the first 10 trials on day 1, and then they came back on day 2 and did later trials. But in early practice trials, we figured we'd see a lot of errors because the task was unfamiliar, they did not know what they had to do, their knowledge of the task wasn't firm, okay? And then what we did was on the second day when we brought them back, we had them do the task again, just to sort of like in the normal setting as we train them, just to make sure they were back on track. And then we added a secondary task. We had them do something called the oral trail making test, where we had them alternate between a number and a letter, okay, in serial. So they had to go 1A, 2B, 3C as they did the task. And we pressed them to do both tasks, to attend to both tasks equally. And so this was our dual task condition, and here we thought we would see errors because of divided attention. And we reasoned that if the resource theory was correct, then we should see similar problems, right, due to no matter what the problem is, no matter why you have problems in everyday tasks, no matter what the reason, you should end up looking the same. You should look like all those other error pies that we showed before, okay? And so we said, well, the early practice should look like the dual task condition, right? Because it doesn't matter what the errors are from, you get the same pattern of errors, and it's really the environment that makes the difference. This is a video that shows what this looks like. I like this because it's such dramatic error. But people really, their error rates really increased under the divided attention condition. And this is a guy just, he puts the coffee filter in the Mr. Coffee filter holder accurately, and then he'll pour water directly in that, and it'll start dripping on them. And he catches it. He'll do like this, go! He is counting. You can't hear it, but he's doing the counting. See, he's okay, so they're making lots of errors. And in fact, on early practice, they had a lot of errors, more than late practice. Then they evened off. And then they made a lot of errors under the dual task condition. Oops. These comparisons were significant. And when we were really looking for omission errors, we only got a significant number of omissions in early practice. Okay. Otherwise, the omission rate was really not significant. So even in the dual task condition, they're making so many errors, they're not omitting anything. And the only time we saw errors, some errors that were not detected, was also in early practice. Dual task condition, again, remember how many errors they're making. They're detecting almost 100% of their errors. We're doing it pretty quickly. So we didn't see a single performance pattern. We actually saw separate, distinct performance patterns on this task, which was not what we were expecting on the resource theory. We saw that in early practice, when people had incomplete knowledge of the task, they were more likely to make omissions, and their errors were more likely to be undetected. In the dual task condition, error rates shot up, okay, because of reduced attention to the task or divided attention to the task. And we saw enormous rates of commission errors, and these were largely detected. At around the same time, one of my students said to me, I want to look at error patterns in people with schizophrenia. And I thought, all right, why not? We'll just add another error pie to the, slap that up on the slide. And what I saw was really interesting, that these two patient populations produce very different error patterns. And then we went back and looked at different subtypes of dementia, and we saw different error patterns there. And most recently, we did something called a latent class analysis that I'll tell you about, where we showed even within patients that have a diagnosis of dementia, you see people showing different types of error patterns. And I'll show you that in a second. But here's the schizophrenia versus dementia comparison. We're now up to 45 people with schizophrenia. These are their demographics. What we did was we took a subsample of dementia patients that matched the patients with schizophrenia on overall level of cognitive impairment using the mini-mental score, and on their total number of errors on the everyday task. So we really wanted to make them really comparable. And that's what we call those people the higher functioning dementia group, because they were more compatible or more similar to the schizophrenia group. And this is the rest of the dementia sample. And what you can see is there really is no difference. There's minimal difference across these two groups in terms of their error patterns. But this was the schizophrenia error pie. And I was pretty shocked and very grateful to my student for having this idea. Because it really made us think that maybe it was possible to find differences across populations, and even when these populations are very similar in terms of their dementia severity and their overall numbers of errors, they're making they're making very different kinds of errors. And what we saw in the schizophrenia sample is that the omission rate was much lower. Okay, so people with schizophrenia are much more likely to complete the task goals. Okay, but the way that they get there is very disorganized, as you might expect. And they're highly prone to distraction, and they're very repetitive in their behaviors. This is just looking only at omission, commission, if you pull them together. Same stuff. The other thing we found with the schizophrenia group is that, first, their rate of omissions and commissions were uncorrelated, so they didn't automatically show. If they showed an increase in omissions, they didn't automatically show an increase in commission. But there are different correlates to these different error types, cognitive correlates. Omissions were strongly related to the mini-mental score, their overall level of cognitive impairment. But commission errors were more strongly associated with measures of executive functions or attentional control. And this made us think, one obvious difference between people with Alzheimer's disease or dementia and schizophrenia is the episodic memory difference. So people with dementia have more profound episodic memory deficits, whereas people with schizophrenia are sort of characterized by their executive deficits, attentional control problems, and their episodic memory relatively preserved. So we looked for, we thought, well, maybe we could find differences like this among dementia patients who also differ on these dimensions. And so people with Alzheimer's disease have more problems, especially in these groups as well. We showed these patients with Alzheimer's disease had worse episodic memory performance than these patients with Parkinson's disease dementia. And these patients with Parkinson's disease dementia had worse performance on measures of attentional control. Okay? And what we found was a significant difference in their error patterns, such that the people with Alzheimer's disease and the episodic memory deficits were more likely to make errors of omission, whereas those with the attentional control problems were much more likely to make errors of commission. This is all starting, it all sort of maps on this coffee challenge idea, where omission errors seem to be related to knowledge or decay of the task goals, and commission errors seem to be associated with attentional control, attention to the task. And here I have a cue that I'm so proud I don't need, as I thought of it before, is that these two patient groups also responded differently to cues. So when we cued our patients, these patients at the end of the task, and we said, your goal was to make toast and coffee. Are you sure that you did that? Is there anything you want to do? Anything more you want to do? So that cue only helped the Alzheimer's group. The Parkinson's group was sort of they were done. They were satisfied. As if one interpretation is that this group did know what the task goals were and they had completed it to the best that they could, whereas the Alzheimer's group may have needed support to maintain the task goals. This is the result from our new latent class analysis with 175 dementia patients of different etiologies. And what this class analysis, sort of like a clustering analysis where you look at patterns within patients. So we look to see not just do omission errors differ from commission errors in terms of their correlates, but do people differ in their patterns of omissions and commissions? And we find that the largest proportion of participants, 68%, showed what I'm calling the modal pattern of errors, which is about 40% omission errors, which is sort of consistent with all those pies, all right, that we had in the beginning. But then there were two other classes of very high error makers. Okay, these people made fewer overall errors. They're comparable in terms of errors, and they're comparable in terms of their level of dementia severity, but they show very different patterns of errors. And one way that you can clearly see that we have a class of omitters, I'm calling them, and a class that's largely committers. Okay, so again, there's another piece of it. So converging evidence that these two error processes really might distinguish people. Okay, we also looked at we used a principal component analysis with a group of 70 participants and looked to see whether or not the errors did dissociate. And we did find two components when we included all of the error types. The first component included omission errors, sequence, substitution, and perseverations, which is what we call commissions, loaded on a second component or a second factor. And additions sort of hovered between the two error types. Omissions in this study were predicted by dementia severity and episodic memory performance when we related it to cognitive testing. In a separate study, we also showed that task knowledge was associated with omission errors and not commission errors. We think that omissions might be due to both degraded representation of the goal in their minds, or sort of task or episodic memory, or their ability to retain that goal over time, and also a failure in linking objects or knowledge of the task with the task goal. So it's almost like a top-down and a bottom-up degradation, that they're not getting the task goal as clearly as it should be represented in people who have intact knowledge and intact memory. And the commission errors were best predicted by errors of executive control in this sample of 70 participants with Alzheimer's disease. And these cognitive correlates, I was really excited to read, have been replicated in a different lab with people who have amnestic mild cognitive impairment. So the same correlates with omissions relating to episodic memory and commissions to different measures of executive control or attentional control. Someone asked me about how these error types might relate to caregiver ratings. What we found is that omission errors are much more strongly related to, these are ADL score and IGERT, caregiver ratings of whether or not a person is independent in a task at home. So much more strongly related to errors of omission than commission. And this relation holds even after controlling for overall level of dementia severity. Okay? And what this might mean is that omission errors might be especially debilitating to people in their homes, or it may mean that caregivers are more tuned into omission errors. It's not entirely clear. We also have found different brain correlates associated with the different error types. This is work from my student Greg. That's supposed to be a funny picture. He does not walk around like that. Yeah, that wouldn't last long in our group. So omissions were more strongly related to measures of hippocampal atrophy, and commissions were more strongly related to measures of white matter integrity. And white matter, the cerebral white matter, is also highly associated to measures of executive control or attentional control, and hippocampal volumes are associated with measures of episodic memory. And additions were just related to everything. We weren't sure what was going on there. And that's work that's done with my colleague Kate Price in the University of Florida, and it's currently under review. And again, we're pleased to see that some of this has also been replicated in a different lab. Jeffrey Zock's lab, this is his postdoc Heather Bailey at the University of St. Louis, have shown that omissions are strongly associated with measures of medial temporal lobe volumes, which is where the hippocampus lives. And commissions are strongly associated to the volumes of the dorsolateral prefrontal cortex. Action additions are associated with volumes of the anterior cingulate cortex, which is kind of interesting, and posterior cortical volumes. This relationship is interesting because in the unexpected direction. So the bigger your volume of the dorsolateral prefrontal cortex, the fewer commission errors you make. I really can't explain that, but for us, we're just sort of excited to see different correlates with different error types. I mean, that's where we are right now. So we're happy with that. So this new series of studies, led to a new model, a new conceptualization for the breakdown of these tasks in patients with dementia. And we have a failure in or problems in task knowledge or episodic memory we think may be associated with errors of omission and degraded error monitoring, whereas problems with cognitive control may be associated with problems in committing or failing to really complete the task in an organized, systematic fashion, even though you do achieve the task objectives. And you still show the ability to detect errors. We're still trying to figure out the addition issue. We're not there yet. And here's an example of how we have used this model to inform an intervention. This is a study done by my graduate student, Brian Betcher. And basically, I'm running out of time, but I'll just try to go through here. What we were really trying to do in this study is attack the omission problem in dementia. So we thought that that was really, because the caregivers were really complaining about it, because they were really omissive relative to people with schizophrenia, we really wanted to see if we could get those omission rates down. And we also wanted to, again, we were troubled by the fact that our previous manipulation didn't really improve error detection, so we really wanted to tackle that. We thought that by increasing the knowledge that people have about these tasks, maybe we can promote error monitoring and reduce omission errors. Again, going back to that coffee challenge idea, right? That where people were, they had poor knowledge of the task, they were more likely to make omissions, they were less likely to detect errors. Maybe that's how some of these dementia patients are operating, in that everything for them is somewhat novel. It's not as, the knowledge of the task is not as firm. So if we can firm that up, okay, maybe we can get them through the task a little bit better. We wanted to improve their task knowledge. We had read a recent paper from the UK where they were able to improve someone's everyday action by training him to learn the scripts, like a verbal account of the task. And we thought maybe we could do something like this, but we don't definitely want to make it verbal with our dementia population. We used videotapes and pictures, and we wanted to make it easy. So we took about 10 minutes before the start of each task just to show them what the steps are. We showed them a video. We asked them questions to make sure they had encoded the information that we presented to them. And then we put cue cards on the tabletop while they did the task so that they didn't have to remember the training. And we did this, this was a between group design because we didn't feel like we could counterbalance this design as effectively as we could the other design. Once you trained them, you really can't erase that training. So what we found was that it worked pretty well. The task training NAT errors were significantly lower. This is where the user-centered error rate is, so it's even reducing those errors even further. Another, again, I always forget these findings. I don't know what to say about them. But we were unable to budge the error pattern. It was the same across the two conditions. So even though we decreased the error rates, okay, we failed at reducing omission rates. The proportion of omissions was the same. Like, we did reduce overall levels of omissions, but that pattern is hard to budge. And unlike the user-centered, here we were successful at increasing error detection. So this is the training task, training NAT. Here is error detection. Okay, that's the standard NAT. And this is the user-centered detection rates. Okay, so this is significant. We were able to increase error detection. So the brief training significantly reduced error rates, but all error types were affected. contrary to what we expected. We did reduce we did increase the proportion of errors that were detected. And from this study, we concluded that degraded task knowledge really might be contributing to poor performance in these patients. Why we didn't get a change in the error pattern, we're really not sure. It is possible that although we intended to target task knowledge, we may have targeted even episodic or attentional. We may have reduced the attentional control required in the task by putting the pictures up. I don't really have a good explanation for it. I don't know. We don't know about the effectiveness of this training. That is, would it work in a naturalist, in the person's real life? We don't expect that once they get training on a task like that, that it would generalize to other tasks. We think that you probably could try this, with your technology, using a smartphone. They could watch a video of the task before they had to execute it, and it should be effective. Sure. But it certainly is interesting and worth looking out for. I know I'm trying to talk quickly. In conclusion, everyday action impairment is heterogeneous. It's not just one thing that, it's not a unidimensional problem. For some people, it may be more of a problem because of task knowledge. For other people, because of episodic memory impairments. But in any case, we don't really know why, but we do know that people are showing different types of problems on these everyday tasks. We think it's possible that interventions might be most effective if they're tailored to the person's specific problem. Although, admittedly, we don't have a lot of evidence for this. We do have to test it. We think that the task training may be improving task knowledge and targeting this problem, but we're not really sure. We haven't tested it against, we haven't administered this intervention to some people who have one problem and another group that has another problem and compared its effectiveness. That would be a nice way to test that. But we do think that user-centered environments are just good for everyone. Okay, so that's why I sort of have that in the background. And we're not yet sure what a good intervention is for a cognitive control problem. We've tried some things with people with schizophrenia and they haven't been all that effective yet. We're still working on it. In the future, we're trying to see whether or not we can find evidence for differential problems, specifically an omission versus commission problem, in people who have MCI or earlier on, if we can detect differences across individuals who are showing early problems in everyday tasks. It would be important to test the validity of the omission-commission model in real-life tasks, which is why what you guys are doing with this smart environment is so fascinating to me. I would love to see if there are people who show different problems in the real world. Improving assessment is important for me because of the my interest in having this work influence clinical practice. I talked to Marie and I realized that clinicians are not going to do these tasks in their clinical setting. So I do feel as though I have a responsibility to try to maybe develop questionnaires or different streamlined tasks that might be able to find these different error patterns in a simpler way. And our goal also is to further evaluate interventions and test this idea that matching an intervention to a specific problem really will be more effective. Again, I think the jury is still out on that based on our data. So in conclusion, what I'd like to do is try to make a difference here by informing the way neuropsychologists think about everyday tasks and having them think about these in a more multidimensional way or more complex way than they have been in clinical practice, and hopefully have this process yield some information about etiology and intervention. Okay. So, whew, that's it. I got through. I was worried I would take too long, and I did go over time. I apologize for that, but thank you for your attention. And I'm happy to address questions if there's time.
I think so. Nobody's knocking the door down. So.
Okay, good.
Any questions?
Yeah.
I had a question about the error detection. Did you actually look at that when you looked at your different classes of cognitive control, or was that just an assumption based on your neural correlates?
I didn't look at haven't looked at error detection yet with the different classes. It's an assumption based on the coffee challenge stuff with the healthy people, and also with some of the work that we've done with the people with individuals with schizophrenia that show that even though they're making lots of errors, their error detection is better than that of dementia patients, although it's not as good with healthy controls.
And is that distinguished between error detection at the end of the task and immediately? Because you were saying that, I think with omission, right, if you prompted them at the end of the task, that they could go back and fix their errors. Was that part of an error detection score? Okay.
No, everything that we included here about error detection had to do with online error detection as the task unfolded, whether they did this or not at the end in terms of their insight. You know, and I think that could be very different. Yeah, we didn't do that. So,
for the error monitoring, if someone went for an object and then realized it wasn't the correct object, are you coding that as error monitoring?
We code that as a microslip, and a microslip is is a detected error. So we code that as error detection.
Okay.
And in some studies we have coded microslips, in others we haven't. So it's not really clear where we have and have not. In the coffee challenge study, we did code microslips. So misreaching to objects.
Okay.
In some of the other dementia studies, we also did look at microslips as well.
And that's different from the error
Yes. So
Okay.
we have we look at whether or not the error is detected is like precluded or like preemptive, like at the timing of that correction.
Okay.
Whether it happens immediately, like before another step is done, and whether or not it's done later. So like a delayed correction. And in people with dementia, for the most part, they are immediate. So they happen immediately after. There aren't a whole lot of delayed, and microslips are present, but I think that if you look at the distribution of their timings, they're more likely to make immediate detections under the standard conditions.
I was curious in your, your omission study, when they're watching the 4 different videos, do you think it might make a difference if instead of just viewing it, that they actually had to imitate what they were viewing? And I was thinking that, they might maybe have more cues in a sense in learning that, or possibly having them learn to chunk things. So maybe these 2 actions, learn those, and then these next 2 actions learn. So kind of breaking the different sequences up into different groups that might relieve a little bit of tax on memory.
Yeah.
Just curious if you thought about that.
That's interesting. I know I flew through that. If they weren't watching 4 different videos, they were seeing the 4 different pictures. They would see those one at a time, and then they would watch a video. Sorry, that was confusing. But I like your idea of teaching them. I think, the other thing that you're getting at too is you're teaching them the hierarchical structure of the task. And Jeff Zaks in St. Louis, do you know about his event segmentation stuff? So he has shown that the people with dementia show worse event segmentation. That is, they're less consistent than healthy people at finding those boundaries. Like toast, put the bread in the toaster is like one boundary, and then we have butter on bread is another chunk, okay? And he also shows that the event segmentation is highly associated with performance on the NAT. So the knowledge of like how these tasks are hierarchically, the subtasks are hierarchically arranged seems to be very important. And so training them on that structure is really a fascinating idea about whether if you train them on the structure, you can really get improvement in performance. I think you would. I think that might even be a more effective way of training task knowledge than just like watch this video without a whole lot of like training, like passively watching it.
Right. Yeah, I was thinking about that just because in Zach's work, a lot of it is very passive where you're watching, you're hitting a button.
Yeah.
There's some suggestion that how you integrate actions together versus how perceptions are seen to occur across time might be more powerful as a grouper of events. So I thought it might be interesting if you combine the two. So in a sense, not only saying this is a segment here, but having them act on it and then pause, that's your segment.
Yeah.
And then, yeah.
Yes. Absolutely. You could really beef up the training of task knowledge. We wanted to see like how far could we get with something that was so minimal, right? Because it would be hard to sell that training regimen. But hey, if that's your spouse,
slowly,
you're gonna be like, all right, come on, here's how we make this coffee. So it depends on
how bad you
who you are. Yeah. I do think that would be really effective. And there may be even a shortcut way of doing it with the videos, like just pausing it a little bit, between the subtasks and
just have them
step 2, something like that. Yeah.
For the draft that you had for the user-centered versus the standard tests that they made, the bars are rather large. Do you have any idea as to why that was? Like, you have an outlier or something?
Let me see. I mean, I think that's an issue for a lot of my work. Let me see. Oh, that's this. I didn't even put the error bars there. I don't think I'm going to have a good answer, but let me look. Here, yes. Yeah, those are enormous error bars. They're standard deviations, not standard error of the mean, which is better, but yeah, there's not any driven by a particular outlier. I just think that there's a lot of variability.
So we talked earlier about the planning manipulation that you guys do. Is that to follow up on the commission errors, or are you doing that?
So the planning manipulation was really started by one of my students who's very interested in rehabilitation. And, in rehab, and one of the first things they'll tackle is, it's very, very common to say, okay, let's help this person plan better and see if they can, if the planning is really, if they have a better formalized plan, they could get through more of the task, right? That's so ubiquitous in rehabilitation. And so we just wanted to test that basic assumption, right? So that's where the planning, she gave people a choice as to whether or not they wanted to plan. I thought this is going to be a real disaster, because what if we have everyone choose to plan and then we have no? But as luck would have it, 50% of college students chose to plan, and it was remarkable. She's very fortunate. And it didn't make a difference in their performance, whether or not they chose to plan before and thought about what they were going to do before they executed tasks. Actually, there was some evidence that those people who chose not to plan did a little bit better. Now, you know, does that mean it's not going to be effective in rehabilitation? These were healthy people. The jury is still out, but it is kind of an interesting finding because you just automatically assume that better pre-planning. I think also, you know, she's a big planner, and she was really disappointed by that. I'm much more of like fly by the seat of my pants out, like, ha! See? Planning's overrated. Go with the flow, Colette. And so it was sort of fun for that. But she's...
Did you get any information about the type of plan that they were using? Because like when I was talking earlier about my one student who did that knock task down there, and we were finding that actually when they executed the task, they did better than their actual plan was.
Yeah.
There could be something about when you get on the task that suggests a better way to go about doing it, and so you may let go of whatever your plan was.
Yes, and that requires a lot of flexibility, and I think that's really a remarkable thing to be able to do, to be able to sort of let go of that if you really are retaining it. But we haven't looked to see how well the plan matched the task. But she did look at like how elaborate the plan was and whether or not within the people who chose to plan, if there was a more elaborate plan, if that would benefit, whether or not it was just sort of like a sparse plan. She didn't find any influence. So it was interesting. She's still working there. Yeah. I'm sorry. Yeah.
Let's go ahead and thank our speaker for the talk. She will be meeting with students or anybody who's interested in talking more in room 130 for the next 2 hours. So you can go there or stay here, but thank you all for coming.
Thanks a lot. Yeah.
Yes. I drew.
Oh, I actually, of course I did. It's my exam day, because I
always would.
I took the bus. So I knew that you drove.
Oh, really?
Yeah. I even like looked. I was like, is it? Look if she drove.
Yep. Always drive. So you're already kind of like partially there.
Oh, you're more entertaining than my line.
Hey, thanks.
Her question was when we took the ride, where did you